in this video lecture, I would be discussing the directly acting sympathomimetics that are non-catecholamines. Directly acting sympathomimetics are the drugs that directly stimulate the adrenergic receptors. So these drugs can be categorized as catecholamines and non-catecholamines. The catecholamines are subclassified as endogenous catecholamines and synthetic catecholamines. Examples of endogenous catecholamines are epinephrine, norepinephrine and dopamine. Synthetic catecholamines include isoprenaline, dipivefrin, dobutamine and phenoldopa. Moving on to non-catecholamines. The non-catecholamines can be subclassified on the basis of receptor selectivity. The alpha-1 receptor agonist drugs are phenylephrine, methoxamine, midodrine, oxymetazoline, xylometazoline and nafazoline. Alpha-2 selective agonist drugs are clonidine, apraclonidine, brimonidine and methyldopa. Beta-1 receptor agonist drugs. There are no drugs with relevant clinical applications in this group. Next we move on to beta-2 receptor agonist drugs. So these drugs include salbutamol, terbutaline, salmeterol and formoterol. So we will be focusing our talk on therapeutic uses of non-catecholamines that act as agonists on adrenergic receptors. So the alpha-1 adrenergic agonists include phenylephrine, methoxamine, midodrine, nafazoline, oxymetazoline, xylometazoline and so on. Phenylephrine. Phenylephrine is the drug of choice for the treatment of septic shock. By acting on the alpha-1 adrenergic receptors of the smooth muscles of the blood vessels, it helps to raise the systemic vascular resistance and helps to restore the blood pressure and is very useful in treating hypotension in septic shock, which is a vasodilatory type of shock. Phenylephrine is also used as a nasal decongestant. By stimulating the alpha-1 receptors of the blood vessels supplying the skin and mucosa, they decrease the blood flow to the mucosa, decreasing the blood volume and decreasing the nasal congestion. Therefore, it is used as a nasal decongestant. The third use. Phenylephrine helps to dilate the size of the pupil causing mydriasis and help in ophthalmoscopic examination. By acting on the alpha-1 adrenergic receptors of the radial muscle of the iris, it causes contraction of the radial muscle of the iris and this helps to dilate the size of the pupil and helps in better visualization of the back chamber of the eye. The next drug, methoxamine. Methoxazine has pharmacological effects similar to that of phenylephrine. The uses and the effects are same as that of phenylephrine. The third drug, midodrine. Midodrine, because of alpha-1 receptor activity, helps to raise the systemic vascular resistance and restore the blood pressure to normal. It is therefore useful for the treatment of postural hypotension, but as a side effect, it can cause hypertension in supine position and therefore it is avoided during bedtime. The other drugs are nafazoline, oxymetazoline and xylometazoline. These drugs are selective alpha-1 receptor agonistic activity and are widely used as nasal decongestants. By stimulating the alpha-1 receptors of the blood vessels supplying the nasal mucosa, they decrease the blood flow to the nasal mucosa, decreasing the congestion and acting as a nasal decongestant. Oxymetazoline has some alpha-2 receptor activity. So by stimulating the alpha-2 receptors, they decrease the norepinephrine release and can cause hypotension. Pseudoephedrine and phenylpropranolone are common cold oral formulations and are used for the relief of nasal congestion. Phenylpropranolone has been withdrawn from India and was reported to have caused hypertension and hemorrhagic stroke. Next, we move on to drugs that act as alpha-2 receptor agonists. Clonidine is an alpha-2 receptor agonist and is useful for the treatment of hypertension with poor renal function. The mechanisms responsible for antihypertensive action are clonidine by stimulating the alpha-2 receptors of the presynaptic nerve ending, reduces the release of norepinephrine, decreasing the sympathetic activity and decreasing the blood pressure. The second mechanism, clonidine by stimulating the alpha-2 receptors of the vasomotor center of the brain decreases the central sympathetic outflow and decreasing the blood pressure. The third mechanism, clonidine also has affinity for imidazoline receptor, that is I1 receptor, and this helps to modulate the alpha-2 receptor, decreasing the sympathetic activity and decreasing the blood pressure. So clonidine through various mechanisms decrease the blood pressure and is useful as an antihypertensive agent. By decreasing the sympathetic activity on the kidney, it reduces the renin release from the kidney, and this decreases the renin-angiotensin-aldosterone system, reducing angiotensin II formation, decreasing the renal vascular resistance, increasing the renal blood flow and improving the renal perfusion. Therefore, clonidine is useful for the treatment of hypertension with poor renal perfusion. However, clonidine has side effects such as drowsiness, sedation. It can cause rebound hypertension due to sudden stoppage of the drug, and also because better alternatives are available for the treatment of hypertension, clonidine use has declined in recent years. The next use. Clonidine is useful to control diarrhea in diabetic patients with autonomic neuropathy. In general, the gastrointestinal system is innervated by sympathetic and parasympathetic neurons. The sympathetic stimulation of the GI tract causes decrease in the motility of the intestine, decreased GI secretions, and contraction of the GI sphincters. Alpha-2 receptors are also present at the presynaptic nerve ending of the cholinergic neurons. Stimulation of alpha-2 receptors of the cholinergic neurons decreases the release of acetylcholine, reducing the motility and secretions, and thereby helps to control diarrhea in diabetic patients with autonomic neuropathy. The third therapeutic use. Clonidine is used as prophylaxis for the treatment of migraine as it reduces the cerebral blood flow. In 1970s, clonidine was first investigated for the management of menopausal hot flashes characterized by feeling of heat, sweating, and flushed skin. Clonidine, by acting on the presynaptic alpha-2 receptors, decreases the norepinephrine release, thereby decreasing the vascular reactivity and reducing the symptoms of menopausal hot flashes. However, the side effects outweigh benefits as clonidine can cause pruritus, drowsiness, sedation, headache, and so on. Clonidine is useful for the management of nicotine, alcohol, and opioid withdrawal. There are symptoms associated with long-term use of nicotine, alcohol, and opioids, and suddenly or abruptly stopping these drugs can lead to withdrawal symptoms, and these symptoms can manifest as increased sympathetic nervous system activity, that is hypertension, tachycardia, and generalized restlessness. So clonidine treatment diminishes the withdrawal symptoms by decreasing the sympathetic nervous system response such as hypertension, tachycardia, and generalized restlessness. The next therapeutic use. Clonidine is useful as a pre-anesthetic medication by acting as an analgesic, sedative, and anxiolytic. They act through agonistic activity on alpha-2 receptors. Another drug that is similar to clonidine action and is useful as a pre-anesthetic medication is dexmedetomidine. So it is a selective alpha-2A agonist and has a more pronounced action compared to that of clonidine. It is very useful for the treatment of ICU patients requiring mechanical ventilation for a long period. Dexmedetomidine is also used in cancer patients for pain relief and reduces the need for opioid use because of its analgesic action. The next therapeutic use of clonidine is it is useful for the treatment of symptoms of attention deficit hyperactivity disorder symptoms. However, it can cause side effects such as pruritus, sedation, drowsiness, and the side effects outweigh the benefits, which is why it has become less popular than methylphenidate. So what is the mode of administration of clonidine? The mode of administration of clonidine can be oral or transdermal. Clonidine has good oral absorption and bioavailability is 100%. Transdermal patches are also available for clonidine and they can be applied on chest and upper part of the arm. The transdermal patches of clonidine release a constant dose of clonidine over a period of 7 days, and when the patch is removed, the plasma concentration remains stable over a period of 8 hours and then declines over a period of several days. Transdermal clonidine patches are very effective for the treatment of labile hypertensive patients who are on multiple antihypertensive medications. They are also useful in patients who cannot take oral medications. They are very effective for the treatment of patients who experience early morning blood pressure surges. The other centrally acting antihypertensive agents are moxonidine and rilmenidine. They have a higher affinity towards imidazoline receptors compared to that of clonidine. And also they have a longer half-life and a more pronounced action. Therefore, side effects such as rebound hypertension, that is more common with clonidine, is less frequent with moxonidine or rilmenidine. These are newer drugs and can be used as antihypertensive agents. The other drugs that act as alpha-2 selective agents are apraclonidine and brimonidine. They are widely used for the management of glaucoma as they reduce the intraocular pressure by acting on the alpha-2 receptors of the ciliary epithelium. By stimulating the alpha-2 receptors of the ciliary epithelium, they reduce the formation of aqueous humor, thereby reducing the intraocular pressure and is helpful in patients with glaucoma. These drugs can also prevent acute rise in intraocular pressure after laser trabeculoplasty. Apraclonidine, unlike clonidine, cannot cross the blood-brain barrier and therefore they produce less central side effects and less systemic side effects are seen with these newer drugs compared to that of clonidine. The next drug that acts as a selective alpha-2 agonist is methyl-dopa. Methyl-dopa gets decarboxylated to methyl dopamine, which further gets converted into alpha-methyl norepinephrine. Alpha-methyl norepinephrine gets stored in the secretory vesicles of the neurons and this substitutes for the norepinephrine, which is the true neurotransmitter. When the adrenergic neuron discharges its neurotransmitter, alpha-methyl norepinephrine is released instead of norepinephrine, and alpha-methyl norepinephrine acts as a false neurotransmitter, and this helps to reduce the sympathetic activation and decreasing the blood pressure. So this is the mechanism which is responsible for its antihypertensive effect. Reduced sympathetic activity reduces the sympathetic activation on the kidney, thereby reducing renin release and decreasing the renin-angiotensin-aldosterone system activation. So this in turn reduces angiotensin II formation and decreases the aldosterone formation. Decreased angiotensin II formation decreases the renal vascular resistance, increasing the renal blood flow to the kidney and thereby improves the renal perfusion. Therefore, methyl-dopa is the preferred drug for the treatment of hypertensive patients with poor renal perfusion. Methyl-dopa is the drug of choice in pregnant women suffering from hypertension as it lacks teratogenic side effects. The other effects of methyl-dopa is that methyl-dopa, by reducing the sympathetic activation on the heart, reduces the workload on the heart, thereby reducing the ventricular muscle mass. So it reduces ventricular hypertrophy. So what are the side effects of methyl-dopa? Hepatotoxicity is a serious toxic effect of methyl-dopa. Therefore, patients should be investigated for liver disease prior to methyl-dopa use, and its use should be avoided in patients with liver disease. Second, immunological reactions can also occur with methyl-dopa use. Autoantibodies can be produced against red blood cells producing hemolytic anemia. Thirdly, methyl dopa is known to cause gynecomastia in males and galactorrhea in females. This is because prolactin release is regulated by dopamine, and methyl dopa, by interfering with the synthesis and secretion of dopamine, interferes with the secretion of prolactin from the anterior pituitary, thereby increasing the prolactin release, leading to gynecomastia in males and galactorrhea in females. Next, we move on to drugs that act as beta-2 selective agonists. The drugs are salbutamol, terbutaline, salmeterol, and formoterol. Salbutamol is a selective beta-2 agonist with relaxant effects on bronchial smooth muscle and uterus. By acting on the beta-2 receptors of the bronchial smooth muscle, they cause dilatation of the bronchial airways and helps to relieve acute symptoms of bronchial asthma. It is commonly used by inhalation route but can also be given orally, intramuscularly, and by slow IV injection. Treatment with salbutamol is associated with side effects such as tremor and palpitation. Salbutamol, by acting on the beta-2 receptors of the uterus, produces relaxation. Therefore, it can be used to arrest uncomplicated premature labor. However, salbutamol use is associated with side effects such as palpitation and tremor. Drugs that have selective beta-2 action on uterus are isosuprene and ritodrine. Because of selective beta-2 action on the uterus, they are used for the management of uncomplicated premature labor and are preferred drugs. The next drug is terbutaline and has an action similar to salbutamol and is used for the relief of symptoms of acute bronchial asthma. The next drug is salmeterol. It is a selective beta-2 agonist and is combined with glucocorticoids in the management of bronchial asthma. It has a prolonged duration of action of 12 hours but has a slow onset of action, which is why it is not an effective drug for the management of acute attack of bronchial asthma, but is very useful for the treatment of nocturnal bronchial asthma. Formoterol, another beta-2 selective agonist, has similar action as that of salmeterol, but the onset of action is quicker and also the duration of action is prolonged. So it is a very useful drug for the treatment of nocturnal asthma and also used for prophylaxis of exercise-induced bronchial asthma. When combined with glucocorticoids, the action is potentiated and they improve asthma control.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.